Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
We want to thank our following sponsors, themetabolicmds.com, a boutique weight loss practice focusing on weight loss through modern technology, the latest GLP-1 weight loss medications, and health coaching. We also want to thank the CGM Doctor, where you can purchase a CGM without a prescription delivered right to your door and also find useful information to get the most from your CGM to improve your health and weight.
Oh, look who's back. We're back here with Dr. Paul Kolodzik, the Metabolic MD / CGM Doctor. By the way, what did you think of the ads that we're running? Those are new for us.
That's nice, Terry. You did a nice job with that.
It's pretty fancy stuff.
Yeah.
Hey, we're going to talk about something fun for all those folks out there who are thinking about getting a CGM or who are struggling with weight or who might be pre-diabetic or even diabetic. We're going to talk a little bit about the history of insulin and maybe a case that you've had recently that will help shed some light on some mistakes some people are making.
Yeah.
Where do you want to start with
or
this?
things they can correct before it can't be reversed. So,
And like
I
you
guess
said,
that's a mistake, isn't it?
well, I did. I made that mistake. I got out of control back probably 15 years ago, maybe 20 years ago, and then I ended up on insulin.
You're always out of control, Terry.
I am always out of control, but that's a lesson for those folks listening out there. So let's dig a little bit into the patient that you've had recently in the ER.
So it was yesterday.
Yesterday.
Okay.
Oh,
yeah.
that is close.
I worked yesterday.
Okay.
And had a patient that came in, and their primary complaint was they're urinating a lot. Okay.
But they were on metformin.
They were on metformin, right?
And he couldn't put two and two together.
So this patient was diagnosed previously diagnosed as pre-diabetic.
Pre-diabetic.
Okay, and was placed on metformin for that.
Which is the standard medicine all general practitioners will give you when you hit a certain...
it's the good first medicine for, elevated blood sugar.
But most times you go visit your doctor and say, okay, well, you got to change your diet, right?
Well,
and
I hope they're saying that.
Yeah, but then you get to metformin.
Then you get to metformin. But for the first thing always should be, low carb approach.
Low carb, but most people won't follow that.
A lot of people don't follow that.
So the doctor says, okay.
And I'll tell you, to digress a little bit, this is, it's like typical American medicine. It's like, here's a pill, and then people get a pill and they think, well, I'm on the pill now. I don't have to watch my diet. So I'm just going to treat this with a pill.
Yeah, I think that's kind of how I thought about it too. I got a pill. I'm going to be good now.
Yeah.
Let's go get that pizza.
Yeah.
So he was on metformin. He was diagnosed pre-diabetic.
Yeah.
Shows him in the ER.
I think also had been a little bit non-compliant with his metformin.
Yeah, I was going to get there. Now, is he overweight?
He was overweight, yes.
Why? I mean, without divulging too, how much overweight you think?
He probably had a BMI in the high 30s, low 40s.
I don't know what that means. What does that mean?
It's so normal is 25 or less.
Yeah.
So that would be an example of somebody that was maybe 5'6" and 330 pounds, something like that.
Oh, yeah. Okay. So they're pretty heavy.
Yeah.
So he wasn't,
and just a very smart guy. Was completing his master's degree. So sounds like a smart guy. But so he wasn't taking his metformin. He was pretending this all go away or something maybe in his mind. Yeah, I don't know. I didn't get into that
psychology
level of
part of it.
Yeah.
And he came in because he was urinating a lot. What was his blood sugar?
So his blood sugar. So initially, you do finger sticks. Even in the emergency department, we'll do finger sticks.
I hate that. If you have a CGM, they still stick my finger.
Okay, they're just correlating it.
They're just making me irritated.
Usually pretty close though, right?
It's very close.
Yeah.
Yeah.
Yeah. That's why CGMs are great.
Finally, I talked to the nurse and just take this reading, and she gave me a break. Okay. Keep going. Go. So you took a finger stick,
and greater than 500, because the finger sticks usually don't read greater than. And the reason we do a finger stick is because I get it back in 30 seconds as opposed to wait for an hour for it to come back from lab.
So I didn't know that finger sticks only read to 500.
Yeah, greater than 500. So, and then we sent it off, and it came back 666.
At what point do people go into coma?
I mean, that's variable, but, and it depends upon, you can actually have people with not a very high blood sugar that end up, progressing in that direction. But the ones I've seen, usually it's 1,000, 1,200 where that
really
can happen. Yeah.
Well,
yeah.
If I hit 200, I'm still pissed off. So
yeah, that's good. That's a good attitude to have.
I guess.
Yeah.
So when you went back to the room and said, listen, Tim, or whoever the guy's name was, you're at...
Oh, I forgot to tell you something else at the beginning.
Ahead.
He came in because he was urinating a lot. I think he was concerned his blood sugar was high. And in my initial conversation, and this was like about 11 o'clock in the morning, he said, well, I'm peeing a lot. I need to have that checked out, and I need to be out of here by 3 p.m.
What?
So...
What?
I think he had some commitment at 3 p.m. and it was like I'm laughing. I hope that's not offending our audience. But it's like
that's how they are.
You've got a life-threatening condition here, guy. It's like and the problem in the emergency department, we've talked about this before. I can do everything in the world to get him out by 3 p.m. He ended up getting admitted. He didn't get out at all yesterday. But the issue is that, I got to wait on lab, I got to wait on x-rays. So
sure.
All those things take time.
So over 600 blood sugar. What did that hit him like a ton of bricks?
Well, it hit him once we discussed the implications. And the implication, and this is kind of the point of our podcast today, the implication was you were on metformin, probably didn't take it as much as you should have. You're overweight. You hadn't watched your diet. Now you're going to be on insulin for the rest of your life.
And did you give him insulin the minute you saw 6, whatever it was?
Yeah. Yeah. Now, yeah. So if it's really high, so I'm not going to get into too much detail, but high blood sugars can be controllable just by giving people, I gave them subcutaneous insulin, just like you take at home.
Yep.
Okay.
It's a lot of fun, by the
way. To
way.
begin to work it down slowly. But if you were in some other parameters.
Work it down slowly. So you don't give them a big dose to get it dropped.
Well, you got to be careful.
Really? Tell me about that, because that might help me.
Well, you just don't want to drop it. You can overshoot the mark, so to speak.
Oh, you can. Absolutely.
Yeah. So that, he could go from 660 to 40, and that would not be good. So it's safer to move kind of incrementally and move him down.
Okay.
And I use subcutaneous insulin because that creates a better opportunity to get him back out of the hospital in a couple days.
What do you mean sub?
So under the skin.
So a needle?
Yeah, a needle under the skin.
What's the other option?
The other option is IV insulin.
I've never heard of that.
Okay, yeah, and IV insulin is used in patients that have progressed a little bit further. There's a bad condition, diabetic coma, you mentioned, called, the formal name is diabetic ketoacidosis.
Okay.
And in those patients, you have to use IV insulin. Their sugar has gone high and their blood has become acidotic. There are different parameters that you can measure related to that. Severe high ketones in their blood. The change, you can measure a pH of blood with something called an arterial blood gas. So people that are in that situation where they're acidotic, then they require IV insulin because of the life-threatening nature of that presentation. But he fortunately didn't have those bad parameters. He was kind of right in the edge there, so we decided to go with subcutaneous insulin, so that we could bring him down and hopefully get him out of the hospital in a couple of days. Because once you require IV insulin, then you got to switch from IV insulin over to subcutaneous insulin before you can send people home, and it's just a longer process.
So, and eventually I want to come back to this, but so if he's on insulin now, I mean, obviously that's going to be a shock. It was a hell of a shock to me when I got pneumonia and they said, listen, you're out of control.
And the point I think we want to make as part of this podcast, unnecessary for most people.
Oh, it absolutely is.
Because if you get a handle on this early on, if you have risk factors, obesity, family history, you're watching your sugar, you're hopefully getting a CGM on your arm periodically, so you know exactly where you are.
Right.
Then you can prevent going down this road.
Well, I can't. Let me just tell you my path, just so people understand what it could be like for them, right? I was overweight. Go to the doctor. He says, well, change your diet. And I tried. Not really, but I tried.
Did you get specific low-carb advice?
No.
Yeah.
Well, I went to some nutritionists, and they were telling me certain things to eat, certain things to avoid. Pasta, I remember, was like, don't do it. And
Okay, good.
yeah, right? So there was something there, but not a lot stuck with me. And then you go back in 6 months later, you go, you didn't, you're still it's still kind of high. We're going to give you a metformin, right? And I said, great, a miracle pill. And it did help, but there's a lot of side effects to metformin.
Yeah, mostly GI side effects.
It was.
Yeah.
And I lasted probably 10 years on that.
Because you were watching your diet then as well? Not as good, huh?
Not as good as now.
Yeah.
With a CGM, you know what the hell's going on. Before you were like, hopefully I'll do better on my next A1C. And a couple of weeks before the A1C, you would watch things. It's like a test. You're studying for your test.
90 days. A1C measures your blood sugar for 90 days.
I gave it 2 weeks.
Okay.
But then, so you go back in, that's out of control. And maybe they'll increase your metformin. Maybe they'll stick something else in with your metformin.
Usually by that time, you're diagnosed as a diabetic.
Oh, I was absolutely diabetic.
Yeah.
And then you try to take those medicines along. Every time you eat, you be popping a pill. And then I got pneumonia, and that just sent me over the edge.
Yeah.
And I ended up on insulin. So those folks out there, one lesson you can learn, if somebody's telling you you might be pre-diabetic, take it serious, right? I would, if you can get a CGM and can afford a CGM, get it, because
over-the-counter CGM. It's $100 for a month.
A month.
Yeah.
It will change your life. If I had that back then, because I hated finger sticks. I'm a guitar player, and I don't want to poke my fingers.
Yeah.
So I didn't, and I would just guess.
Yeah.
And I was always wrong.
Yeah.
All right. So let's go back to your patient.
Okay.
So now he's got his blood sugar lowered.
Okay, we've lowered his blood sugar in the emergency department. He's getting admitted to the hospital. The other thing we do is we give him a lot of fluids, IV fluids, which kind of dilutes your blood sugar out.
That's why I'm drinking this.
Yeah.
You see me drink 3 or 4 of these while I'm here. Yeah.
So, and that is not an alcoholic beverage that Terry's drinking, but
no.
Yeah.
I feel like I should be on one.
Okay.
So you got, how long do you think he'll be in the hospital?
Hopefully no more than 2 or 3 days.
And then,
but a lot of that is diabetic teaching that goes on to that.
Oh yeah.
You got to learn, how to use, how to administer insulin, how to check your blood sugar frequently, all that kind of stuff.
To be honest with you, I didn't get a lot of that. I should have probably got more. They basically said, start little pins, right? You dial in the pin.
Yeah.
And you start at a certain dose. And then maybe you don't start high and go low. You start low and work your way up high.
Well, and there's different combinations. There's long-acting insulin and short-acting insulin.
I'm on both.
Yeah.
Right. So I take a long-acting in the morning and then take another shot with every meal. So I'm 4 times a day.
So we modified his blood sugar, got him admitted to the hospital. All that'll go on over a couple of days, and then he'll go home, and medically he'll be fine, except, I don't think he will ever get off insulin. And the lesson here is, again, you can avoid going down that road.
Oh, yeah.
Even if you just have risk factors, obesity, family history, and certainly if you're pre-diabetic, pre-diabetes is completely reversible. Usually once you cross that threshold to diabetes, it's not reversible. Now, the good news is, and I've had many, many patients over the last 5 years where we've been able to put their diabetes in remission. We've been able, by diet, to get them off medication. Even some patients, we've been able to greatly reduce their insulin. And occasionally I even get a patient off insulin, but they still have that underlying insulin resistance. So I can't say they're cured of their diabetes.
Right.
The term that I use is we've put your diabetes in remission for a period of time, but sometimes that can be years.
Well, I promise you, I guarantee you, if I had known what I know today, and they had, like, back then, if they had low-carb bread and the substitutes and sugar-free things, back then, I guarantee I don't think I'd be on insulin right now.
Yeah, good.
Well,
Hey, let's talk about, so we were talking about metformin before we got on here.
yeah.
And Terry says, well, my daughter went on metformin. Tell me a little bit about that.
So my daughter, who's getting married, and her fiance is a doctor, and they decided to go on metformin, and she's not overweight, and he's definitely not overweight. So I called her up right before we did this podcast. I said, Megan, what the heck are you on metformin? She goes, I was, but I didn't. I went off of it because she was taking other things. I said, why did you do that? She said, to reduce sugar spikes. But I didn't realize that she was worried about sugar spikes, because we've heard that metformin can help you with all kinds of other things. I guess it's sugar spike related.
So metformin has become popular in recent years for a variety of reasons. Now, metformin's not without risks. There are GI side effects. There can be some serious risks that are very rare,
Right.
As well with metformin. But it is used as a weight loss medication at times. Because it can moderate your blood sugar. It's just the things we've talked about over the years here. Bring down your blood sugar. And when your blood sugar is lower, then your body turns to your fat as a source of energy.
Right.
So it has been used for weight loss. And then it's getting some popularity now related to general. I'm using this term very general. Anti-aging and longevity. In fact, there's a current trial in process to look at that. But I guess the belief is that metformin can slow aging by reducing oxidative stress, which is the stress that occurs from free radicals in your body, so decrease inflammation.
Does GLP-1 you think have the same effect, or because they're dealing in the same general areas? Blood spikes.
Lowering your blood sugar, you're doing that.
Yeah.
So yeah, but so metformin has got this increased notoriety. Some people think it will slow cognitive decline.
Is that because we think high blood sugar is related to?
That's what I believe. That's a good insight, Terry. I mean, it's been proven for years that diabetics have a much higher rate of dementia than people that don't have high blood sugar. And I think just if it's modifying or moderating your blood sugar, then there's probably an advantage there.
Well, so if you come visit me sometime in a home and I'm don't remember your name, you'll know it has true effect on me. What else we want to talk about on metformin?
Well, just the other thing I think we wanted to, not necessarily on metformin, but just on the whole issue of diabetes and its management in general. So, I mean, it's hard to believe, but we just passed the 100-year anniversary of the 100-year anniversary of the discovery of insulin. So
100 years?
100 years. Yeah.
Really?
Yeah.
But they didn't have the cool pens back then. They had a big. Remember how big needles were back then?
Yeah.
They were small, little, tiny needles.
Well, I mean, the pens are, I think new in the last 15 to 20 years.
Oh, I love the pen.
The way insulin was commonly dosed was people got a vial and they drew it up on their own.
That'd be hard.
So,
I know people are still doing it with some medications, but most things are going toward a pen, aren't they?
Yeah. Yeah, I mean, it's easier. They're more expensive, but it's a lot easier, and I think there are fewer dosing errors associated with that. But can you imagine a world that we were talking about this? What was the treatment for being diabetic before insulin existed?
Yeah, my mom, who's be 102 now if she was still living, had an aunt. So when she heard I was diabetic, obviously she goes back to the time when she was born in 1921. So I had Aunt Betty. She was a diabetic. All she could eat was turnip greens.
Yeah. It's a low-carb diet, the original low-carb diet.
Yeah, but she's telling me that, and I'm scared to death about this whole thing. And I'm thinking I'm going to be eating turnip greens the rest of my life.
But it's just amazing. I mean, it's only, think about it. It's only 100 years.
Was it a pig? Was it pig insulin or so? How did they figure? Do we know?
Yeah, initially it was porcine. And in fact, I think there was... that was available up until maybe 25 or 30 years ago. And then I think it was Genentech, the biopharmaceutical company, that came out with the first synthetically produced insulin. So, but without insulin, just think all the people we know now that are diabetic or type 1s and type 2s be without that. So obviously a great thing. Invented by Dr. Banting, a Canadian doctor. So when your president is bashing Canada, then the one, good thing we should remember is
only one of us here voted for him. So it wasn't this guy.
Canada gave us insulin, and we should be thankful for that. We should lower their tariffs because of that.
We won't get into that conversation, but all right. So interesting facts. We talked about metformin. Talked about your patient. You think he's going to be okay?
Yeah, he's going to be okay. It's just that unfortunately, unnecessary. Like most, and I don't mean this to be incriminating or a negative statement. But if you're overweight, you can prevent becoming a diabetic. And the way to do that is what I've preached for years. Low carb reduces insulin resistance. Intermittent fasting reduces insulin resistance. And strength training, because bigger muscle mass reduces insulin resistance. So, part of what we've been preaching for years is people can empower themselves to control their health going forward. And I think, people can do for themselves much more than the medical system or any doctor will ever do for them, just by educating and empowering themselves. And, if you got a problem, addressing it or reversing those trends.
All right. So if we haven't put them to sleep yet,
okay,
let's put them to sleep with a talk. Let's just go ahead and plug your book.
Oh, yeah. And if you want to learn how to reverse your insulin resistance, then the Continuous Glucose Monitor Revolution is the book for you. Best-selling book on Amazon on how to get a 2-week CGM and see what's going on with your blood sugar. And it'll change it. I guarantee you it'll change. I know it sounds trite, but it's like once you see that, if you're one of those people that are near prediabetes or you're pre-diabetic and you see that data on your phone, I mean, it's like, a doctor can be telling you for years to do this, or your family can be nagging you about your weight or whatever. But once you see the data there, it can be life-changing.
That little thing on my phone has changed me, because if I see like I'm high, I go, I ain't going to eat that. Like I went to Olive Garden. I love Olive Garden. Because of the price, it's good, salad's fantastic, breadsticks, all that crap. But boy, that set me high. And we split a spaghetti. Yeah. But it still sends me.
And would you agree that once you see that data and you understand it, correct me if I'm wrong, because this is the way I feel, you just gravitate away from eating those foods. Yeah. And it's not as much as a challenge as it was previously. I mean, you just do. I don't know. I guess the term I would use is you don't desire those foods as much as you used to.
I agree. I used to eat. I love French fries. I used to eat them all the time. Hardly eat them anymore. Yeah. I eat a half a. It's changed me, just because you don't want to see those spikes go too high. So you're always adjusting for that.
And once you've had a CGM on and you've seen it, even if you don't have a CGM on, continuously going forward at that time, the way my patients say, I'll say it again, once I've seen it, I can't unsee it. Right. So even if they don't have a CGM on at that point, they know what those French fries are going to do. Oh, yeah. And I'm not saying, I have days that my carbs are higher than others, special family dinner or something like that. So it doesn't have to be an absolute thing, but it certainly modifies things going forward. And I think makes your dietary adherence it's not even adherence. It just makes your dietary approach, that much easier.
I totally agree. All right. At that point, we're going to end this podcast because we've talked about everything we wanted to talk about. And what have I missed?
The websites?
We mentioned it up front, didn't we? Oh, I mean, if you're interested in CGM, you own a business that actually will deliver CGMs to your door,
and
no prescription.
Not only do that, but provide a lot of education on the topics that we talk about here. So that is CGM Doctor doctor.com.
Yeah.
Or for the people that reside in Ohio, Indiana, Florida, and Arizona, if you're interested in learning more about what we've talked about on these podcasts, want to become a patient, at least for a 2-week trial awareness CGM, it is metabolicmds.com, metabolicmds.com. Was that too brazen?
No, I mean, we want to avoid being too pushy, but I would tell you, anybody out there, just try a CGM. Not that I care about getting him any business. Try a CGM, because once you see the data, you'll either know, yeah, I'm in good shape, or you'll know, I got an issue I got to look out for. If you see it, you can fix it.
Yeah.
Yeah.
And this one, one of the reasons I'm passionate about this is because, this wasn't as big an issue 40 or 50 years ago.
Are we going down the food pyramid period?
Well, I won't even bring up the food pyramid, but we didn't have the obesity issue.
No.
40 or 50 years ago. So it wasn't as big a thing because we ate differently 40 or 50 years ago. But now it is a big deal, with 60% of American adults being overweight.
All right. Well, let's leave them on a happy note then.
All right.
All right, folks. This has been the Metabolic MD with Dr. Paul Kolodzik. I'm Terry O'Brien, the producer. We'll see you guys all real soon. Bye.